Hello everyone, welcome to my YouTube channel. Today we are going to talk about subtrochanteric fracture femur fixation dilemma. Before we start, there is a disclaimer. This video is for informative purposes only. I am advising you to refer to the main textbook or sources that is used in each teaching center respectively. Thank you. Now let's begin. How you define a subtrochanteric femur region? It is defined as a region within 5 cm distal to the lesser trochanter. Subtrochanteric fracture often also associated with intertrochanteric fracture. Question: how do you manage a subtrochanteric fracture femur? Surgical intervention is a standard procedure. Traction is just a temporary measure. We can use a skin traction or skeletal traction. The aim is to restore the leg length and alignment, provide the pain relief, limit blood loss. Before any surgical intervention could be done or while awaiting surgery. Non-operative management is rarely used due to the risk of limb shortening, malrotation, complication of prolonged bedridden, and complication of prolonged traction, especially in an elderly patient. Why nailing is a standard of the treatment for femur fracture? The reason: A. It reduces the blood loss. B. It reduces the operating time. C. Superior biomechanical strength compared to plate. D. Less complication compared to open reduction. E. Faster time to weight bearing. Even though femoral nailing is a standard management for femoral fracture, there are certain conditions whereby biologic plating might be advantaged. Example, in A. Closed medullary cavity, because there is a presence of another implant, or sclerosis of the medullary cavity. B. Very narrow medullary cavity, which can cause heat necrosis during reaming. C. Presence of contamination of entry point of the nail. D. Suspicion or proof of intramedullary sequestrum. E. Increased bowing of femur that does not allow the insertion of nail. In such cases, additional osteotomy need to be considered. F. In an open fracture with vascular injury, biologic plating is an advantage. Subtrochanteric femur fracture is difficult among shaft fracture to treat because of intraoperative difficulty in reduction. Varus malalignment over the subtrochanteric region is common due to the action of the surrounding musculature. The proximal fragment will be abducted due to the action of gluteus medius and gluteus minimus, insertion at the greater trochanteric of the femur. The fragment will be in flex position due to insertion of iliac psoas at the lesser trochanter. The distal fragment will be in adduction, medialization, and shortening. It is due to the action of adductor muscle. So, if there is a question about why there is a risk of malalignment in nailing for subtrochanteric femur fracture, you can answer one of it is because of action of each muscle attached at the greater trochanter and lesser trochanter. Question: why varus malalignment is a problem? Subtrochanteric region experience the highest value of forces during weight bearing up to 1200 lbs per square inch. Varus malreduction causing an increase in bending stresses. Varus malreduction will lead to an increased mechanical stress on the fixation construct by altering the weight-bearing force vector through the proximal segment. This will contribute to a higher compressive forces on the medial cortex that may lead to iatrogenic fracture during nail insertion. Later, abductor efficiency will be reduced due to more proximal position of the greater trochanter. Varus angulation will disturb the normal transmission of the force across the knee that will lead to degenerative arthropathy that contribute to the progression of osteoarthritis of the knee. But the quoted journal said that the study is a small, still inconclusive. But if we understand biomechanics and forces that acts on the knee, it is possible. Now the question. Which one is higher risk in entry point during nail insertion? Greater tuberosity region or the piriformis entry point? Well, there is a comparable result for both techniques. For GT entry point, the advantage are 1. Technically easier due to subcutaneous location of the GT, especially helpful in an obese patient. 2. Less sensitive to anterior-posterior translation due to more cancellous nature of trochanteric area, and it reduces the risk of iatrogenic bursting of proximal segment. In GT entry, number 3, it reduces the risk of damaging blood supply of the femoral head because of the more lateral approach. Number 4, less destructive to abductor musculature. And another advantage of GT entry is less blood loss. Disadvantage of GT entry is there is a risk of varus malreduction is higher. The risk of iatrogenic fracture of GT also there. Advantages of piriformis entry point is it reduces the incidence of varus malreduction. It reduces the medial cortex injury during rimming. The disadvantage of piriformis entry point is 1. Difficult obtaining proper starting point in obese patient, in patient with hypertrophic short external rotators, in patient who has a greater trochanter overhang. Number 2, disadvantage of piriformis entry point is there is an increase of anterior cortical blowout due to excessive anterior placement of starting point. 3. Risk of injury to the blood supply of the femoral neck via injury via medial circumflex femoral artery MCFA. Number 4, iatrogenic neck of femur fracture. Question. How to reduce varus malalignment during intraoperative manipulation? We can use either closed or open method. For closed method, we can use a traction table intraoperatively. Under supine position, after clean and drape, we can use an F-shaped reduction tool. An anterior directed leg support for the distal segment. We can use a crutches. If we fail the closed method, open reduction need to be done via A. Small percutaneous stab wound to facilitate the clamp placement or by periosteal elevator to overcome the muscle forces. If fail, then B. We can do a small incision over the fracture site and the second clamp is placed at the distal segment to help in reduction. Another tool that can be used to help in reduction are Homer retractor, Bennett bone lever retractor to put on the medial surface of the femur, or bone hook to assist in reduction. Last question. Before we end this session, how to diagnose varus malalignment via radiograph? Before that, I will add in regarding the definition of anatomical axis and mechanical axis. Anatomical axis is defined as a line drawn through the center of diameter of the aphysis of each bone segment at two levels. For mechanical axis, it refers to the angle by a line drawn from the center of femoral head to the intercondylar notch of the distal femur. So how to diagnose varus malalignment via radiograph is by measuring the varus angulation more than 10 degree at the fracture site in anterior posterior radiograph. Okay, that's all for today. I hope you gain knowledge from this presentation. Till we meet again, bye.